Uh, Good afternoon, everyone. Uh, it's become part of one of my regular duties to introduce our grand round speakers. That's a great honor, and today's no exception. Our speaker today is Dr. Jonathan Bolton, who's a professor of psychiatry. I'm sure he's well known to everyone. In addition to his medical degree, as if that wasn't enough of an accomplishment, he also holds a Master of Arts, Masters of Philosophy, and a Masters of Medical Management degree. He practices through the faculty clinic as well as the ACT team, and also serves as the director of the Health Sciences Center Institute of Ethics. So I'm happy to turn over the Zoom podium to Dr. Bolton and sit back and learn today about how to train excellent psychiatrists. Dr. Bolton, thank you.
Thank you, Dr. Varela. And this is always the most anxiety-inducing step, trying to put the slide up. So let's see if this works. Good. Okay. All right. Well, thank you. This is obviously a marketing title. So we're going to talk about what excellent means. But I wanted to first, obviously, wish you a happy Halloween. And for people who don't know our faculty, this is our faculty on Halloween. So, as educators of our profession, we have the duty to ensure that every resident knows what is currently true and is capable of performing the essential functions of a psychiatrist. And if we do that, then we are ensuring that our residents are competent by the time they graduate. However, if we want at least some residents to become excellent psychiatrists, we must do more. And it's this gap between competence and excellence I'm most interested in. By definition, statistically, most psychiatrists are competent, but only a few will be or become excellent. And I'm going to make an argument for what an excellent psychiatrist is and what we need to teach in order to help those residents who want to become excellent psychiatrists. So what is an excellent psychiatrist? And we might disagree on this. Some might argue that an excellent psychiatrist is a researcher, or an excellent psychiatrist is an expert in medications or a particular form of somatic therapy, or even that an excellent psychiatrist is an obedient, loyal employee. My opinion, or my view, was informed by Peter Kramer's I think it was his earliest book, called Moments of Engagement, in which he described his training and the early stages of his practice. And although he didn't say it, his presentation of an ideal psychiatrist is something like a Swiss Army knife, capable of making diagnoses, using current medications, but also capable of using individual psychotherapy, making changes in the patient's immediate group, all to reduce mental suffering. Now, his book was published in '94, and his model of an excellent psychiatrist maybe was a little more common or widely held in that decade or the decade before. So our task is really to define a model for our present or near-term future. We need to know what we believe an excellent psychiatrist is now, so that we can design our training programs to encourage it. And I'm going to make an argument that we should hold on to this generalist model as the basis of excellence, at least during general psychiatric training. So we use this word excellence. What does it mean? It's a more general question. And I'm going to use a modified sort of Aristotelian concept of excellence. And Aristotle argued that in order to achieve the highest purpose in life, flourishing or happiness, the person first must be free to choose his or her actions, and then choose to act virtuously. And he distinguished two general types of virtue: character virtues and intellectual virtues. And for him and Plato and others at the time, the important character virtues were courage, temperance, and justice. For us, we can wonder, well, what are the character virtues necessary for excellence as a psychiatrist? They might be compassion or truth-mindedness or honesty or thoroughness or something like that. I don't actually know, this is Dr. Sauer's domain, I don't actually know how we select for these character virtues in our residents, but I'm always struck by the character virtues that our residents actually do have. The ones that we select seem really fantastic in this domain. The other class is intellectual virtues, and that really relates to making wise decisions. So the excellent psychiatrist is a wise psychiatrist who knows what is right and good in each case and is capable of doing it. I'm going to focus on the intellectual virtue of practical wisdom as something that can be learned and taught. I'm not going to talk about character virtues here. So a second general question is, what is all this about? What are we trying to do? What's the telos or the goal of psychiatry? What do we try to do when we practice psychiatry? And I think that in the broader sense, it is to reduce mental suffering. Now, mental suffering is not unitary. It has many different causes, many different manifestations. So ideally, psychiatrists are able to treat each cause using the best methods for the particular cause. So to illustrate, I'd like to present three cases that could be seen on any day in our PES. So in each case, the patient is a 47-year-old woman, an employee of the university and not known to the mental health center. And each patient has the same symptoms. They feel sad, they feel hopeless about feeling better, they haven't been eating, their sleep is off, they feel tired every day, have a vague sense of responsibility for feeling this way, they can't enjoy their usual activities, and they have occasional thoughts about dying. So the first patient has a history of recurrent major depressions since her early 20s, and also a history of hypothyroidism. And she stopped taking both her antidepressant meds and her levothyroxine about 6 months ago. And for the last month, she has felt a return of familiar symptoms. Second patient was recently divorced after suffering abuse. Her ex-husband is a pastor. She has not told anybody about the abuse. She feels ashamed. She feels she has sacrificed herself for her husband's success. She feels confused about her relationship with the church, and she's lost access to the congregation. And the third patient is bullied at her work by her boss. She feels put down, worthless, embarrassed. She wonders if it's because she's Black and overweight. She's noticed other people moving away from her. She feels stigmatized and marginalized. And she never knows if she's doing a good job or not. Her boss confuses her. When they interact, she says things like, on the one hand, she says, be independent, show us what you've got. On the other hand, she says, always check with me first. I hate surprises. So what would an excellent psychiatrist do in each case? The excellent psychiatrist will be able to identify different types of mental suffering and be able to use the best methods to reduce each type. At the very least, an excellent psychiatrist would not mistake one form of suffering for another, and they wouldn't use the same treatment for all three patients. The excellent psychiatrist will be wary of words that patients use to describe their experience. So when they hear a patient say, I'm depressed, they don't immediately assume that they know what that means, or that it means the same as whatever is encoded in DSM. Actually, this happened to me yesterday. I had a patient who just had a manic episode and did some things during that episode that she is remorseful over now. And we were talking, and she said, well, I think I'm depressed again. And as we were talking more, she didn't seem to have any of those neurovegetative symptoms. What she did feel was shame. She was ashamed of what she had done. And so if I had taken the word depression at face value, I would have gone in one direction. Whereas if a better explanation is shame, then we would go in a different direction. So we need to understand about the causes of mental suffering. And when we consider different causes of suffering, we can use different lenses to observe the patient, and we see different things. When we use a somatic lens, we see the patient as an organism. When we use a psychological lens, we see the patient as a person. When we use a social lens, we see the patient as a member of a group or a culture. So let's take each type in turn. So starting with some somatic causes. In this, the focus is on a patient as an organism that's prone to breakdown or malfunction. The patient suffers because their body fails them due to disease or disorder or something like that. And we can work through the different causes of somatic suffering. We could use that mnemonic that we used in med school, learned in med school, to sort of try to identify the different somatic causes to the suffering that we see. And we think of this domain as involving diseases, syndromes. And we understand, we believe the patients suffer because they have a disease or because they have a disorder. And this is very much the same perspective that physicians in other fields use, and it's the basis for our claim to be a medical specialty. So the second perspective is person level or psychological causes of suffering. And this lens would have us view the patient as a person. So a person is a sui generis level of organization or analysis, and it's between sort of the level of organs and bodily processes and the supra-individual level of groups. And this level was very much more theorized when psychoanalysis was the dominant theory and method in psychiatry. A person can be divided into their public aspect and their private aspect, and each can be a locus of suffering. The public self is the self that's known to others, the self that modifies its behaviors because of others. And the public self can be a source of suffering. It might be that there's a mismatch between it and their private self, or the expectations of the public self might just be too much, or they might worry about something that damages their reputation. The private self is the inner self, the self that has desires, fears, feels pain, feels shame, feels joy, guilt. It's the self that acts for itself. And distress or suffering of the private self can arise from intrapsychic conflict, that's something that the Freudians focus on, or from deficits or distortions in development, something that Kohut would focus on, traumatic experiences, and so on. So this is the domain that psychotherapists try to access and change. And psychotherapists have developed a complex body of concepts and dynamic patterns that to make sense of this kind of suffering, this kind of mental suffering. And these concepts we all know: defense mechanisms, unconscious, transference, cognitive distortions, core beliefs, personality, and so on. And these concepts are not reducible to biological concepts that have been developed to explain functioning and suffering at the organismal level. This is the domain of psychodynamics. So there are lots of causes of person-level suffering, loss, uncertainty, cognitive distortions, loneliness, etc. It's a long list. And the third lens would have us look at social suffering. So a patient is not just an organism or a person. He or she is also a member of various groups, a family, clan, tribe, congregation, work group, organization, faculty, and so on. And the person experiences emotions, joy, satisfaction, suffering, as a result of their membership in these groups and their roles in these groups. So, for example, a person who has a bad boss, their life at work will be much more miserable than it would be otherwise, all other things being equal. So, group dynamics can result in a person feeling marginalized, alone, scapegoated. So the psychiatrist has to be aware of how various socio-dynamics arise and cause suffering in group members. And the causes of social suffering are also really long. So estrangement, oppression, toxic groups, toxic leaders, unsafe environments, strain in status or roles, and so on. Now, obviously, these causes, the somatic, the psychological, and somatic, they're not independent. They can overlap in individual cases. And the intersection in that Venn diagram is actually a domain or a zone where we can disagree as professionals about what's causing what. But we can still sort of generally cluster the causes of mental suffering into those three general domains. So then we have to figure out what to do. We can understand the type of suffering that a person has, but we have to do something about it. And different causes of suffering require different treatment methods. All treatments that aim to reduce mental suffering must change something, but what they aim to change will differ. Somatic treatments change the body. Psychological treatments change the person's insight or behaviors. And social treatments change the way the group functions or how the person fits in with their group. Of course, every particular instance of suffering can involve more than one cause. A person might have a biological cause, a person-level cause, and a social cause. And some patients can be successfully treated with one modality, and others require a combination of different modalities. On the face of it, somatic causes of suffering are best treated by somatic interventions. Likewise, psychological causes are best treated with psychological methods and social causes by social methods. In practice, or in reality, cross-category interventions are often used by the clinician, but also by the patient. So, for example, psychological or social suffering might be treated by us using a benzo or an SSRI, or by the patient who uses drugs or alcohol. And each of these reduces the symptoms by directly affecting the brain. That said, they would leave untouched the psychological and the social causes of their suffering. So let's take each category in turn. So somatic interventions, these are treatments that reduce mental suffering by changing the state of the body. We're really good at this. We use medications, we use forces, magnetic forces, electrical forces. This is the domain of Chris Abbott, Davin Quinn. We use light therapy. We might use surgery. Of course, in the past, we used to use other things that we no longer use, like hydrotherapy, insulin coma therapy, and psychosurgery in a big way. Social interventions aim to reduce suffering by inducing changes in the patient's social environment or group. It could be a dyad, could be a triad, a small group, family, or a larger group. And these interventions include couples therapy, family therapy, 12-step programs, and so on. Possibly one of the most famous examples of social interventions in psychiatry was done by George Brown and his colleagues at the Institute of Psychiatry in London. And that after they discovered that some communication patterns that are used by family members are associated with a higher risk of relapse for patients with schizophrenia. And actually afterwards, every other psychiatric condition that was studied, except borderline personality disorder. They found that hypercritical comments or hyperintrusive communication events drove this distress, which resulted in a relapse. So they then intervened by trying to change the family's communication structure. And the result was improved or lower risk of relapse. So very famous social intervention. At the level of person, these are psychological interventions, mostly the most developed we call psychotherapy. And there's a vast range of these, and they vary in their goals and what they try to achieve, but they also vary in the means that they use to achieve the goals. Some aim at radical changes in the patient's personality. Others have more modest goals of better adjustment to life situation or reducing symptoms. And we can categorize this vast range, hundreds and hundreds of psychotherapies. We can use sort of this triangle to categorize it. We can distinguish between insight-oriented or exploratory psychotherapies, supportive psychotherapies, and directive psychotherapies. And I'm not going to, as I said, there are so many of these different types of psychotherapy. I'm not going to do anything more than just sketch the domain and focus a little on the three types of psychotherapies. First, exploratory or insight-oriented psychotherapies. And most of these probably were derived from Freud's writings in the theory and practice of psychoanalysis. And they emphasize the emancipatory potential of self-understanding. A person who has insight is able to, into why they do what they do, is able to stop doing it, basically. So in this approach, the therapist or analyst notices patterns of behavior and thoughts, and the goal is to make sense of them. And if they can be made sense of, they can be changed, and the patient is freed from them. This approach emphasizes the unconscious origins of actions and how their libidinous, aggressive, self-assertive urges are over, under, or mismanaged by the person. And these therapies are sometimes called anxiety-provoking therapies, and partly by intent. Inducing anxiety can make the patient's primary processing or your primitive thinking or primitive defense mechanisms more accessible. And also because this approach really talks about difficult stuff, sex, aggression, attachments. In practice, this approach focuses on what happens in the room between the therapist and the patient. Is called working in the transference. And the presumption is that the patient acts in the therapeutic setting in ways that are similar to how they learn to act in other situations, in other relationships. So the therapist has direct access to the recreations of these earlier behaviors and experiences. Now, not every patient can develop a working transference, and certainly most patients can't commit to the time and the expense of this form of therapy. And psychodynamic psychotherapy was never considered sufficient for all psychological causes of suffering. So supportive psychotherapy is actually probably the most commonly practiced psychotherapy, even if it's under-theorized and has more modest goals than psychodynamic psychotherapy. Initially, it was reserved for patients who couldn't do insight-oriented therapy because either they didn't have the intelligence for it or they had an unstable personality structure that prevented them from establishing a working transference relationship with the therapist. Supportive therapy is pragmatic. Its goals are to promote self-esteem, reduce anxiety, shore up ego functions, promote adaptive skills. And the therapist nurtures more mature defense mechanisms such as humor or rationalization, intellectualization. And the supportive therapist tries to help the person to regulate their activities and affect. And they do this by encouragement or cheerleading or praising skills or reassurance, modeling, that sort of thing. It's not opposed to the use of medications if the meds support those goals. So they're not opposed to anxiolytics or antipsychotics, whereas an insight-oriented therapist might be. So if insight-oriented therapy is anxiety-provoking, this approach, supportive psychotherapy, is our anxiety reducing. The goal isn't emancipation through insight, but to reduce suffering through better adaptation, better coping, impulse control, reality testing, and by improving the patient's confidence and self-esteem. So from all of this, it'll be clear that this really is probably what most therapists do in actual practice. The fact that it's under-theorized is a real problem for it, but nonetheless, we need to be trained in how to do it. So insight-oriented therapies, and especially like Carl Rogers' client-centered psychotherapy, typically try to avoid telling the patient what they should do to feel better. And obviously, they avoid manipulating the patient. But in directive therapies, by contrast, the therapist takes a much more active role in guiding, advising, prescribing courses of action. And the goal is to move the patient toward behaviors that are better oriented to reality, reducing irrational anxieties, and so on. Sometimes it's done openly, like in cognitive therapy and behavioral therapy, and sometimes it's done surreptitiously, as encouraged by people like Milton Erickson and Jay Haley in individual therapy, and by Salvador Minuchin in structural family therapy. So these in actual practice, these overlap. In actual practice, all but the most dogmatic psychotherapists are eclectic. They routinely borrow from different approaches depending upon the case. I remember my therapist, who was a dyed-in-the-wool analyst, I remember catching him or noticing that he was using a cognitive therapy approach with me. And I thought, wow, that's interesting. And I actually asked him about it. And he said, well, the hardest thing for a psychoanalyst to do is psychotherapy, by which I think he meant he had to adjust his methods when doing psychotherapy, and he became more eclectic. So this means that, oh, I don't have a slide. This means that in psychotherapy training, we must, at the minimum, expose residents to representative theoreticians of the most established forms of psychotherapy. And if the goal is to actually train excellent psychiatrists, to provide opportunities to learn by practicing them. All right, so what are the implications? None of this is new to most people on this Zoom. I apologize for sort of going a little deeper into some of these domains, but here are my concerns. As a field, we are getting much better at treating somatic suffering, and I'm glad about that. That is a good thing. But we are losing our abilities to treat psychological and social suffering, not to mention losing our interest in doing it. We've lost our confidence in the theory behind these approaches, these interventions, and in our skills to do it. On top of that, we are not reimbursed at equivalent rates to provide non-somatic treatments. And because of this, the organizations we work for prefer to have other people, usually lower paid clinicians, to do this work. And the result is that psychiatry is at risk of being reduced in what it thinks it can and should do. So in the face of this reality, it might seem quixotic to advocate for residency training to continue to teach psychotherapy and group therapies. So why is it not quixotic? to do this. First relates to effectiveness. My argument has been that because psychiatry has the goal of reducing mental suffering, and because mental suffering is heterogeneous, it's not unitary, psychiatrists must be able to distinguish different types of suffering and ideally be able to treat all forms. If they can't practice some techniques, we're not all equally adept in all forms, then we should be able to collaborate with people who do have those skills, but have the knowledge to know what they're doing, why they're doing it, and to not make it more difficult for them to do. So I argue against cordoning off somatic causes, somatic treatments for psychiatry, and then ceding the rest, all the other forms of mental suffering, to other clinicians. One reason for not doing that is that even the most somatic cause or case of mental suffering eventually includes psychological and social factors that can influence the arc or the course of that person's illness. We also need to understand the intersects between the domains, between the somatic, the psychological, and the social, and how to best design treatments for it. So actually, ironically, when psychiatry was in its psychoanalytic era, many psychiatrists cordoned off psychological suffering and then ceded the rest to other forms of clinicians, and that wasn't good either. Second issue is pluralism and eclecticism. There is no sufficient theory or treatment for all mental suffering. We must be willing and able to switch between our methods depending upon the case. So an excellent psychiatrist is a pluralist. They're able to switch between somatic, psychological, and social interventions. And the excellent psychiatrist will be eclectic when choosing among the different approaches within those domains. So we need to know within psychotherapy, is a transference-based approach good for this patient or not? Is a directive psychotherapy best for this patient? Which means that we must learn the theory and practice of a number of different psychotherapies. At the minimum, our training should include cognitive therapy, psychodynamics therapy, behavioral therapy, supportive therapy, and so on. And the same goes for social or group-based treatments. We should know how groups can cause mental suffering in their members. And we should learn through experience in group therapy, family therapy, couples therapy, how to correct those harms. The third consideration really is self-protection. Learning about psychological or person-based suffering, social or group-based suffering, reduces the risk that we will consider all cases to be somatic suffering, and therefore always and only prescribe a somatic treatment. It's not just our own biases that are at risk. We encounter other non-psychiatrists who, for various reasons, believe that a case should be treated somatically. I can't tell you the number of times that I've heard psychologists or other mental health professionals who I work with leap to wanting to recommend TMS or ECT or some other powerful somatic treatment, when my interpretation is that the case would benefit from powerful psychological or group-based treatments. So patients similarly might have read about the latest or seen the ad on TV for the latest, greatest drug, and unless we have a formulation that protects us from that, we're likely to go down that path. So we have to be knowledgeable enough about these other domains to withstand the fears and the fantasies that others might have about the case. So as clinicians, as apical clinicians of mental suffering, we should be the best trained and the wisest clinicians. Even if we don't practice psychotherapy or group therapy, we need to know when it is indicated, what the risks and benefits are, and how it is done. I believe personally, and I've said this to residents, that it is psychotherapy training that saves us from being just bad neurologists. The fourth consideration is really market advantage. It's going to be a losing strategy for us to focus only on somatic treatments. As nurse practitioners, clinical psychologists, physician assistants get the privilege to prescribe medications, our slice of that somatic treatment market is going to shrink. And typically, those non-physician prescribers have very little training in psychological and social interventions. And if we are effective in those modalities, we can maintain our competitive advantage in the, to be crass about it, the marketplace of mental suffering. So, and also, we can also act as a coordinator of different treatments if we have this ability to talk the talk of these different domains. All right, so reactions. This might strike many as asking way too much of psychiatrists, and it may be. But if we're talking about being excellent psychiatrists, I don't see a way around it. I think a psychiatrist can only be excellent if, sorry, let me rephrase that. A psychiatrist cannot be excellent if they can only treat one type of suffering using only one type of treatment. So, training. If we accept this as the overall clinical responsibility of excellent psychiatrists, how should we design our training programs to encourage our residents to become excellent psychiatrists? What's required? First is attitude change. In many training programs, psychotherapy is considered an afterthought or an unproven holdover from an earlier era in psychiatry's evolution. In major academic medical centers, expertise in psychotherapy is not considered a smart career move. Again, a complete reversal from the time when you couldn't be a chair of a psychiatry department without having psychoanalytic training. It's even more true for social therapies. So if we're going to do more than just merely comply with the ACGME's Psychiatry Review Committee's requirements, we actually have to believe that there is a reason to teach non-somatic treatments. The second is, it's not a great term, but ghettoization. In many programs, the mandate to teach psychotherapy is delegated to one or two faculty members who have an interest or varying degrees of expertise in psychotherapy. Often nobody teaches social interventions like group therapy, family therapy, couples therapy. Instead, what is needed is in every training site, on every clinical service, inpatient, outpatient, child, geriatrics, CL, substance use, emergency medicine, faculty members should do the same thing to help residents to identify different kinds of mental suffering that they are encountering, and when indicated, to use non-somatic treatments alone or in conjunction with somatic treatments. Third, we should focus on training our residents to be excellent generalists before they become subspecialists. We shouldn't give those residents who have interests in research or a subspecialty a social pass, because the same knowledge and the same skills we're talking about are relevant to every subfield of psychiatry. At the very least, every psychiatry resident should be expected to be able to develop a biopsychosocial case formulation, not just diagnoses, and comprehensive treatment plans. Lastly, accountability. We convey our values by what we hold our trainees accountable to. Jordan Cohen, who led the AAMC, said that students only respect what you inspect. And if we believe that non-somatic theory and practice is important to psychiatry, we have to expect our residents to learn it, and we have to inspect how well they are doing it. So obviously, this isn't the place. We don't have the time today to talk in detail about how to introduce curricular changes. That's best done in the education committee meetings or in conferences like the AAP. So in conclusion, I've presented a vision of an excellent psychiatrist as a professional clinician who can understand and treat the widest range of mental suffering using a broad range of methods. The excellent psychiatrist is a Swiss Army knife more than a hammer. Now, not every psychiatrist will want to learn or do this kind of clinical work. That said, I believe it's a vision of what psychiatry can be and what we and something that we should expose our trainees to in the hope that at least some of them will choose to become excellent psychiatrists. So with that, I'm going to come back to you all. So I'm sure there are things that you will disagree with in this pitch. Please, any thoughts, objections, comments, renovations? Hi, Avi.
Jonathan, thanks so much for a wonderful talk. You alluded to something else, and I was wondering if there might be a fourth domain, which is our focus is often on individuals as opposed to being population-based. And especially as a child psychiatrist who's often been in a position where there's not another child psychiatrist for 200 miles radius,
Yeah.
the idea is that you look at what a whole community needs. And that also relates to something also that you alluded to, which is that we cannot just be the bridge between all sorts of psychiatric or psychosocial interventions, but also with medicine, so that we can have a holistic view. So maybe our training should look at how do we deal with populations and communities, and how do we integrate within the healthcare system at large, not just the mental health care system.
I agree with both. I found that if I added more dimensions, my triangle was going to become a rhombus or something ungeometric. And I've thought about the public health aspect, and I know family medicine is particularly good at including this in their training and in how they see their practice. And maybe that is a good fourth dimension or the fourth dimension to add. And I would love to sort of know how to do it. It doesn't feel close to my own set of sort of experiences in terms of when I'm working with individual patients, but that doesn't mean we can't broaden the definition of an excellent psychiatrist to include that.
Related to that is this other decision too about if you are looking at a population, should you have highly specialized and intensive treatment for a few, or much more services for the larger population, which might be, time limited, or rely on other professionals, even peer support workers, community support workers, that kind of thing. But having that point of view in our training doesn't really emphasize that at all.
No, I agree, and that's maybe we could add that to the conversation. Yeah. Any other reactions or?
I have a question, Dr. Bolton.
Yeah.
I really enjoyed this talk, and I know we've had some conversations about this before, but I'm curious, can you speak on, I know you said that this isn't enough time to talk about how you would go about teaching some of this, but I have to wonder, when we're thinking about teaching some of these skills, if it goes beyond sort of academic conversations about them, and do we need more exposure of residents to seeing what good psychiatry looks like, being able to actually observe it, and how do you create that or how do you add that to a curriculum?
Yeah, it's a great question, and I think that first we have to decide if we want to do that. I think there are probably going to be arguments against the argument I made. And interestingly, the chancellor of my program, from the place where I went to residency, made a strenuous argument against this approach. He thought that psychiatrists should just focus on the somatic side. So I think we need to be convinced, one, that this is right or good. I think secondly, we need to address whatever keeps our confidence low in terms of doing this. I think we need to believe that all of us can incorporate these perspectives into our work and then into our teaching. So raising confidence in us as teachers and practitioners, and resisting the urge to, or the sort of pressure to become just somatic. And then trying to find ways, as I said, in every, not at the curriculum, but in every work site, having conversations in the PS, about, what is going on with this person's crisis? Is it simply that she hasn't been taking her meds for 6 months, or is it a crisis of self, or a crisis of social estrangement? And just starting to talk out loud about that, and not being satisfied with the diagnosis of major depressive disorder, for example. So I think those are 3 areas I would start off with. And then doing more of what Jeff Katzman did. He brought experts in. If we don't have it here, if we don't have experts in, couples therapy, if we don't have experts or in, some form of psychotherapy, decide that that's what we want to include in our training. And then maybe in terms of things that we have to do with our residents, like, I can never remember the name of the clinical interview exam, but really making that a real thing. When we had to do it as part of our boards, that was a real thing. And the chair of my department where I trained failed twice because he didn't take it seriously as a real thing. And we need to really use that opportunity to encourage residents to construct broad case formulations and to elaborate on non-somatic interventions that they might consider. So I don't know if that's helpful, Dominique, but those are things that come to mind shooting from the hip. But there are people here who are far more actively engaged in education, and maybe they are doing this already that I don't know about. But those settings, the settings that Dr. Varela, Dr. Sauer run, could be great fora for expanding this. Yeah. Dr. Sauer.
Thank you so much for the presentation, Dr. Bolton. I really appreciate you highlighting and providing depth to the conversation. I think one piece that I have continued to sit with is how we sometimes really separate, and we tend to see things as like, okay, this is, in training, for example, right? Like, this is the CBT training, this is the psychodynamic, this is other types of training, or where we talk about, like our practice doing med management or doing therapy, right? As opposed to like really the holistic practice of being a psychiatrist, which hopefully intertwines all of those in terms of assessment and treatment, and what we're doing, whether it's a 10-minute session or a 60-minute session. So yeah, I think that's something that I always come back to, and I think we like to consider as part of education is like, how do we support people in having a holistic view in that way in terms of their role as psychiatrists. But yeah, it's a work in progress, I think, in terms of structuring that. And if you have, I feel like you've touched on it through the presentation, if you have any other thoughts, but it is something that, see as a priority.
Yeah, I think we've sort of balkanized psychiatry, and then different people will sort of occupy the Balkans that we've created. But that patient that I mentioned who has, as far as I can tell, bipolar disorder, wondering at the person level, not at the organismal level, what does that do to her? What does the experience of mania change in terms of her sense of self? So I think our patients are the locus where we can bring these different perspectives to bear and to focus. And, this patient also now has marital difficulties because of, what happened. So, so there you got biological, psychological, and social all in one patient. And for me, just to adjust lithium and not even talk to her about the other things, I think we're not really doing the kind of psychiatry that I think we should be doing. So in a sense, it's kind of a resistance against the momentum of our field toward balkanizing it. I don't know if that came close to comment, but
That was helpful. Thank you.
Dan.
Hi, Dr. Bolton, thank you for inviting me to attend today. And I was wondering, for those of you who don't know me, I'm not a psychiatrist. I work in medical ethics with a focus in psychiatric ethics. But I was just thinking of certain contexts where somatic medicine might be the only available sort of modality to get effective care in. So like in correctional psychiatry, for most of the anecdotes I've heard from people that work in that setting, you can't really provide one-on-one therapy. There's certain dangers to providing group therapy of people, becoming emotionally vulnerable to others, and often their med management seems to be the primary focus. But even there seem to be great limitations, issues of medication diversion and whatnot. And so, in a setting like that, I was wondering on your view, just given those numbers of sort of feasibility worries, it seems to kind of, I wonder if an excellent psychiatrist would just avoid that setting altogether on your view. And similarly with like large health systems where the emphasis is on efficiency and volume, I think that you do get cultural pressures there more into somatic medicine because all the other stuff just takes so much time.
Yeah,
I'll stop there.
No, Dan, thank you first. And I think there are sort of real world impediments to doing the kind of psychiatry I'm talking about. And I should never work in a jail because I'm too naive. People will see it too quickly. But that said, on the face of it, prison right off the bat would immediately affect this person level suffering and create social suffering. So even if it's practically difficult to instantiate interventions, it should still be part of your formulation, I think, and also you shouldn't believe that treating with meds is going to really, there are going to be limits on what you can do because of those social and psychological factors. So, and then as for working in a, in a setting where you are disallowed from doing this kind of psychiatry, that's your choice. Nobody makes you do that work. And it's an ethical decision. And if you want to do that kind of work, fine, but you're not going to be practicing excellent psychiatry. And that's on you.
Thank you.
Anybody going to take a counter argument as to why this is idealistic, outdated, anachronistic, idealistic, something you simply just don't want to do?
Um,
Oh, sorry.
oh,
Go ahead.
I'll just say that I agree with like everything you shared today. I will just add that like I never really felt comfortable or a high degree of trust in myself as providing therapy. As someone who was more traditionally trained, like a psychology degree, a master's, and maybe even a doctorate degree, and so I always tried my best, and I felt like this program here had a good therapy emphasis, and I think still does for psychiatry training in general. But I did doubt myself, like, am I really serving this person as well as a classically trained psychotherapist who knows the DSM from cover to cover and does this full time would be able to? And so there's a bit of self-doubt with it. With that said, I really feel like the things that you shared today, like us having an awareness of the different principles of psychotherapy and being able to implement that in the work that we routinely do, which is this predominantly medication heavy, is important because that can be some of the things that help with some of the other goals that we may be trying to achieve with like medication adherence and whatnot. So I don't know what thoughts you have about those of us who are psychiatrists that have self-doubt about the quality of therapy that we are providing or attempting to.
Uh, well, interestingly, I have the obverse or the inverse of you, Dr. L. I don't feel confident in my psychopharm abilities, so I have the same lack of confidence, but I still have to do it. So I'm not saying you have to get somebody on the couch. It's maybe the first thing that I would want for all of us is just to broaden our sensitivity to what is causing a person suffering. And if you don't want to do therapy, that's it. Nobody's saying you have to. And if but it's more, I think the first part is just having a broader appreciation of the causes for any particular case. And there are very few people out there who simply only have a somatic cause, I believe. So just being sensitive to what's contributing or a perpetuating factor. And then, you can assign your residents to do therapy on the inpatient unit. So, but thank you. That is true. And I don't want to say that everybody has to be a therapist. I'm not saying that. But yeah, enough said. But thank you. Dr. Nim, did you?
Yeah, I was gonna say, from how you describe everything, I think that's really kind of my residency that I did. They were very therapy focused and kind of touted that as how they're special, I guess. And as a resident going through a type of program like that, I think with time constraints and your own anxiety about learning psychopharm, it was really hard. But in hindsight, now I realize like how lucky I was to be able to go through training like that. I think we're talking about two different things here, right? We're focusing on training and residency where you should have time to be able to talk through these things and think through these things. And it should be different than your regular everyday training, right? And I think yes, it is hard, but I think if it's kind of built in to the system and kind of is a philosophy that everyone adopts, then you can do it. You gave the example of like in the PES sitting down and talking through patients, and that was really what we were expected to do. And as a resident, it was frustrating. But now looking back, like I'm so thankful because we saw a lot of patients and you got to talk through a lot of patients and really think through a lot of different things. Whereas, when you go outside of training, yes, I can sit down and read a psychopharm book on my own, but how much of an opportunity am I going to have to kind of talk through kind of psychodynamic stuff about my patients? Not much. So I think having that unique opportunity in training is really important. Yeah, it is hard, but it's important.
Yeah, it's also very interesting. And if you have residents now, you can use that opportunity to talk it through with them. So it's win-win.
Yeah.
Well, I think we're at the witching hour. So thank you, everybody, for your attention and for your comments, and see you around.